سعد الله صباحكم جميعا. بلش اليوم موضوع جديد هو النيونيتال كير فارماكوثيرابي. طبعا هذا التشابتر بس بحب انبه يا شباب انه غيرنا الريفرنس تبعه، لانه الريفرنس اللي في الكتاب انا راح احط لكم التشابتر ان شاء الله اون بالاي ليرنينج، فهو تشابتر 11 اي من اخر طبعه من ديبيرو اللي هي 11th edition. فإن شاء الله راح يكون طبعا هذه هي الشابتر المعتمد، لأنه هذاك الشابتر اللي في الريفرنس اللي موجود في السيلبس طويل كثير بصراحة، يعني very very large، فارتأيت إنه أخفف شوية و to include this يعني instead of the other chapter. النيونيتال كير راح نركز على بعض الديزيزز يعني المعينة اللي هي بعض الانفكشنز، راح نركز على بعض الكارديوفاسكولار وريسبيراتوري سيستم. فبنبلش بأول موضوع بموضوعنا اليوم هو neonatal sepsis and meningitis. Again all of these diseases احنا بنحكي عنها بنركز على فئة معينة من المرضى اللي هم neonates، وبفترض انه عارفين ايش تعريف النيونيت من خلال المحاضرات السابقة وعرفناها طبعا. فأول شيء بنبلش فيه هو بالكلينيكال بريزنتيشن بالنيونيتال سابسيس ومننجايتس. They vary by the gestational age و severity of infection. إذا راح نشوف خلال التريتمنت لما نحط التريتمنت موداليتي أو therapeutic consideration all the time we're talking about what age of that neonate in terms of is newborn ولا premature ولا full term. راح نركز على هذه الأشياء. الشيء الآخر هو severity of the infection. Is this how severe is that infection? It's ranging from non-specific to multi-organ failure بعض الأحيان ممكن يكون عندنا. The premature infants usually they are present with apnea, bradycardia, cyanosis, lethargy, while term infants will present with respiratory distress. فبعض الساينز والسيمتومز طبعا تكون initially في حالة النيونيتال sepsis ومننجايتس including the sign and symptoms انه بنلاحظ الطفل انه he is rejecting or she is rejecting to eat. poor feeding normally associated because they'll lose appetite. They are irritable or they have irritability. They are lethargic, hypothermia, even though there is infection, but they are hypothermic unless the fever is coming from a febrile mother during birth. فthe neonate اللي مولود حديث جدا ممكن ياخذ هذا الفيفر من الام بعض الاحيان. فعلى الاغلب اذا كان في عندهم neonatal sepsis or meningitis بيكون عندهم hypothermia، لكن بعض الاحيان fever but it's not common. It's uncommon unless that febrile coming from mother. On the respiratory system, they might have apnea, tachypnea, grunting, and nasal flaring. Grunting is the facial expression يعني of feeling pain or feeling difficulty breathing. On the cardiac side, they might have cyanosis, desaturation. That's why they have cyanosis, bluish in color due to desaturation of oxygen. Bradycardia, poor perfusion, metabolic acidosis, and they might also suffer from hypotension. So the clinical presentation for neonatal sepsis and meningitis would include as late complications, of course, of a neonatal infection. They include jaundice. After we talked about the initial symptoms, but later in the process they might have jaundice or hepatosplenomegaly or respiratory failure, severe metabolic acidosis, bone marrow dysfunction like neutropenia and thrombocytopenia, and disseminated intravascular coagulation. And most infants with EOS, the early onset sepsis, as we talked about it last time, will be present within the first 24 to 48 hours of life. This is the majority of them. And generally, those with gram-negative and fungal infections will have more severe symptoms than those with gram-positive infections. Therefore راح نشوف بعد شوي انه التريتمنت بعض الاحيان بدنا نسال انفسنا السؤال: is this suspected microorganism belongs to the gram-positive or the gram-negative bacteria? Is this a fungal infection or it's a viral infection? So this is important in the assessment of the infant or the baby, the neonate. It's important to perform a thorough review of antenatal risk factors. What are the risk factors that are available when evaluating an infant for suspected sepsis and meningitis? Do they have higher risk factors? The presence, for example, of rash, seizures, or liver dysfunction is leading to a suspicion of a viral infection like the hepatitis HSV virus اللي هو واحد من viral infections that would affect and leading to meningitis, for example. The diagnostic and laboratory findings. So what laboratory tests I can perform in the case of a neonate? So as you see, several laboratory tests. They are not differential diagnosis or they are not specific, but most probably they will do a CBC for white blood count or white blood cell with differential. We need to see the level of neutrophils, lymphocytes, etc. Urine culture, and urine culture more in the late onset sepsis rather than the early onset sepsis. Sometimes for meningitis, all of you know the diagnostic tool is to have the LP or lumbar puncture for cell count and culture from that CSF, cerebrospinal fluid. And the gold standard for diagnosis of a neonatal sepsis is to isolate the causative microorganism in a blood culture. So that's the gold standard. So this way, you will have a definite diagnosis that this is what's causing the sepsis or meningitis. This is the problem. I have isolated this microorganism in a blood culture, and hence I will give the exact susceptible antibiotic that would be effective in this situation. White blood cell with differential and the ratio of immature to total neutrophils are commonly used also as a screening test for neonatal sepsis, but poor sensitivity and specificity. So we can use them as a tool, لكن عندي مشكلة في sensitivity والspecificity of these tests، يعني اللي هو white blood cell والdifferential. استخدم من ضمنهم اللي هو I to T ratio بنسميها، فالimmature to total neutrophils نستخدمها كانديكيتور، لكن it's not highly sensitive or specific. On the other hand, neutropenia, for example, is more sensitive or has more sensitivity. In viral infections, be careful that white blood cell count normally is within normal range. Other laboratory measures you could also make is the CRP or the C-reactive protein, and we all know that C-reactive protein is an inflammatory biomarker. It indicates there is inflammation. And another biomarker or laboratory test we could do is a prolactin also, or PCT. What are the common pathogens that are implicated in neonatal sepsis and meningitis? Before that, I would like to mention something about the Kaiser neonatal sepsis calculator. This is a tool used to assess the need for antibiotic. هل بنحتاج antibiotic therapy and laboratory monitoring for early onset of infants who are more than 34 weeks gestation. Based on maternal risk factors ناخذها بعين الاعتبار. إذا بتشوف على اليمين هون هذه الصورة عبارة عن بيسأل أسئلة عن المذر، يعني هو هل في risk factors من الماتيرنال side بإضافة إلى الانفانت's clinical examination. Excuse me. So an infant's clinical examination, you examine the infant and you tell what is the duration of a treatment, what is the optimum antibiotic that's going to be effective in this case. So there are advantages associated with this calculator and there are certain disadvantages. Among the advantages is significantly reduced antibiotic use. Instead of using higher doses or combinations or for longer duration of action, this tool will give you kind of a prediction of what to use for how long. It has the advantage of also lowering hospitalization among patients or neonates and the need for a blood culture evaluation. It's a time-consuming, invasive procedure, taking blood samples, doing a culture, so it will reduce the need. Do we need a culture? Yes, but not as frequent as without this tool. The disadvantages, on the other hand, of this Kaiser neonatal sepsis calculator is not validated for use in a preterm infants. We said the age should be gestational age more than 34 weeks. Now, if the infant is below that, it's kind of not validated in that age category. It does not provide guidance on the duration of antibiotic therapy. It's just what is the dose and the selection of that antibiotic. So that leads us to the treatment now, which is the most important for us, is the pharmacotherapy of neonatal sepsis and meningitis. And we have, at the beginning, we need to go through what we call it empiric antibiotic therapy for early onset sepsis. So empiric because we don't know the causative microorganism yet. So we give an empiric بدائية، يعني antibiotic في البداية بنعطيها حتى بنشك بشيء معين، فبنعطي antibiotic حتى ما نضيع الوقت. فاحنا بنعطي هذا الانتيبيوتيك وبانتظار بعد ما ناخذ الكلتشر، طبعا بنبلش بالانتيبيوتيك بانتظار نتائج الكلتشر حتى تطلع. It should be initiated in infants with suspected sepsis. Once a blood culture is taken, then should target the most common pathogens. من experience بتحدد انه what are the most common pathogens causes sepsis or meningitis in this age category, then you target accordingly. Normally they have antibiotic stewardship, they have a list of most commonly used antibiotics with their regimens and their doses ready to be used until the culture, then you optimize the treatment after you get the results from that culture. So further delay on antibiotic. Why do we need to have a kind of empiric antibiotic therapy at the beginning? Because if we delay antibiotic initiation, the results may have significant increase in morbidity and mortality. Imagine leaving sepsis or meningitis untreated for longer time. So that's why we need to not delay antibiotic initiation. So the most commonly used antibiotics, think about the combination of ampicillin and aminoglycosides like gentamicin or tobramycin. This combination is normally or commonly initiated for early onset sepsis. This combination, it covers E. coli, we know E. coli is a gram-negative, and has synergistic activity against group B, streptococcus, and L monocytogenes. So that's an advantage for this combination. These antibiotics are working by their bactericidal effect against most common neonatal pathogens. They also penetrate into the central nervous system because of the infection, or sepsis is also in the meninges or in the cerebrospinal fluid. So I need an antibiotic that has distribution or penetration into the central nervous system. To be effective at the end of the day, I also need to have a safe antibiotic. So the first thing that you think of is ampicillin and aminoglycoside like gentamicin or tobramycin. Now, the dose of ampicillin when suspected meningitis, what dose should we give? The meningitic doses of ampicillin, which are higher than normal or that are used with other infections, should be used until meningitis is ruled out, because you don't know exactly what is causing this. Is this sepsis or meningitis? We don't know. So use a higher dose of ampicillin, because you're giving antibiotic anyway. You want to make sure that this antibiotic is effective until you get the results. Selection of a specific aminoglycoside should be determined again by what we call it a NICU, neonate intensive care unit, or a newborn intensive care unit specific antibiogram. Antibiogram, it's antibiotic like diagram or chart. It's kind of giving you extrapolation of what dose should be given to that neonate. So this antibiogram, it's kind of a curve, will give you what is the corresponding dose relative to body weight. Of course, we'll take body weight and age in this calculation. So amikacin is generally reserved for gram-negative organisms which are resistant to gentamicin or tobramycin. So if I give you the option to use an aminoglycosides, initially, which one would you select? Normally gentamicin or tobramycin. Then as a second line, you would take amikacin if there is resistance to other aminoglycosides. When dosing aminoglycosides, we need to be very careful about the dose also, to be safe, and we need to achieve efficacy, of course. So safety, you know, aminoglycosides, they're ototoxicity and they are nephrotoxic. On the other hand, we need something to be effective as well. We need to achieve a therapeutic serum concentration that should lead to the killing of the microorganisms in standard study. So the therapeutic concentration, we think about the concentration in the serum, think about the peak concentrations at least 8 to 10 times greater than the minimum inhibitory concentration of the organism being treated. So as you know, in antibiotics, we have the minimum inhibitory concentration that will kill like 50%, I think, or the MIC 50. This MIC 50 is the minimum inhibitory concentration. We need to go up more, like 8 or 10-fold or times greater than this MIC. And the low trough concentration, sorry, I lost connection here. And the low trough concentration is lower than 1 microgram per ml. So we need to have a peak concentration above that minimum. And the low trough, a trough is the lowest concentration, should be very low in order to finish or end the drug action, or to avoid side effects also. So traditional dosing of aminoglycosides was 2.5 milligram per kg per dose every 8 hours. This is a typical regimen they normally used. This dosing strategy resulted in supratherapeutic peak concentration due to higher volume of distribution. So that 2.5 is the traditional way they used to calculate it in the past. لكن في عندنا مشكلة هون. المشكلة إنه هذه بتصير sub-therapeutic peak. Sub-therapeutic, it means under the desired concentration. ليش؟ لأنه صار عندي volume of distribution in this neonate is different from adults. if you compare it to an adult. Number two, supratherapeutic trough concentration due to slower renal elimination. So think about the antibiotic you will give it, you will reach a peak, then it will go down just before the next dose. You will have a supratherapeutic trough. That trough also, it means the body is not getting rid of this antibiotic. Then the consequence is accumulation of that drug. So it's not regular. That's what I'm trying to say. Currently, most institutions then they utilized what we call it extended interval dosing, or EID, of aminoglycosides in neonates. So the EID is the extended interval that will cover a longer period of time, where a higher dose of the aminoglycosides, say 4 to 5. So it's almost 2 times the dose we were talking about here. The regular one is the 2.5. Now we're giving almost double. They are given at prolonged dosing intervals. Instead of every 8 hours, now we give it every 24 or 36 or even 48 hours, depending on the age of the neonate. So again, this is the new technique they are following in most of the institutions now, to use the extended interval dosing for aminoglycosides. And again, this is specific for aminoglycosides, to make sure that we don't go above or below the required concentrations. So the EID, let's say the EID or EID of gentamicin has achieved significantly more therapeutic peak, which is within the effective range, and the trough concentration without increasing nephrotoxicity and ototoxicity, compared with multiple daily dosing in both term and preterm neonates. So the idea in those children, remember when we talked about the pharmacokinetic characteristics and the pharmacodynamics, those children, they have a higher chance of variability in pharmacokinetics of the drugs. Absorption is different, distribution is different, metabolism is different, elimination is different. Therefore, I don't want to reach a nephrotoxic or ototoxic dose. At the same time, I don't want to lose efficacy of that aminoglycoside. And the extended dosing in those neonates should not be confused with the extended dosing in adults. In adults, yes, they might exceed the toxic dose, but in infants, they are different. So I want you to distinguish between the two, the extended dosing in children for aminoglycosides versus adults. There are differences. In adults, aminoglycosides are generally dosed once daily, and the rationale for this extended dosing is to enhance bacterial killing by providing higher peak serum concentration to minimum inhibitory concentration ratio and minimizing the post-exposure. At the same time, we need to avoid resistance, microbial resistance, by achieving a drug-free period. So the advantage is you're going up to the effective concentration to make sure you're killing the bacterial in study or causing the infection. At the same time, we need to go below the trough in order to have periods of very low concentration or no concentration to avoid microbial resistance toward this aminoglycosides. This is what we call a drug-free period. So that's why the extended treatment or dosing strategy here is different in infants. And when using this, the peak concentration are usually around 20 to 25 microgram Remember, we're talking about 2.5. It's about 10 times now. This is the concentration, sorry, in milliliter or milligram per mil in blood, while trough concentrations are not detectable here because they are going below the trough. So again, we need to reach the highest concentration possible to make sure we have enhanced bacterial killing. At the same time, we need to reach times of a drug-free period. The drug-free period here, it's important because it's kind of decreasing the risk of antibiotic or microbial resistance toward that antibiotic. Furthermore, a nomogram, normally it's a chart, also is used to guide dosing interval adjustment. You adjust the dose based on the 8 to 12 hours post-dose single serum concentration. So you take a serum concentration or blood sample and measure the concentration, then again utilize that nomogram to guide you. This is a picture of one of the nomograms. Again, there are some more complicated than this. It will give you the right dosage regimen for antibiotics in children. Now, in contrast, the extended dosing regimen of aminoglycosides and neonates is different from that. Peak concentrations are usually between 8 to 12 microgram per ml. It's almost half of the previous number, or maybe one third, while trough concentrations are usually low but detectable in adults. Protein peak and trough concentrations that we follow, they are also needed for neonates, as there is no nomogram available to guide dosing adjustments. إذا ما عندنا nomogram adjustment إلهم، فلذلك هذه الروتين peak and trough concentration are also needed to guide through dosing. Another potential antibiotic that we could use also in neonatal sepsis and meningitis is cefotaxime. It's a third-generation cephalosporin and may be added or used in place of gentamicin in the infants who are suspected with a gram-negative meningitis. It has a greater CNS penetration compared with aminoglycosides, and it also has the advantage of less nephrotoxicity. It does not require serum drug concentration measurements like gentamicin, for example. Therefore, I think it's more convenient, but it has a problem on the other hand. It has been associated with development of resistant gram-negative bacilli such as Enterobacter clostriae, and increased risk for invasive candidiasis and the necrotizing tissue and tissue, and death also is common. Therefore, it's kind of considered kind of less safety profile, except that nephrotoxic thing. So it should be reserved then for neonates with suspected meningitis or those with aminoglycoside resistant gram-negative bacilli. كان عنده gram-negative bacilli وكان عنده resistant هذا microorganism towards aminoglycosides, and the other option is use this third-generation cephalosporin, cefotaxime. It's also reserved for those patients where serum gentamicin concentrations are not available at their institution. You cannot measure gentamicin, for example, at this hospital. Then the alternative is using cefotaxime because you're not sure what the trough and peak concentration of gentamicin in that condition. It's also reserved for those patients with significantly impaired kidney function because of the nephrotoxicity of gentamicin and aminoglycosides. Then the alternative is to give cefotaxime. Another antibiotic is also a cephalosporin ceftriaxone. It's a highly protein-bound antibiotic. Should not be used in neonates due to its risk however, of kernicterus, secondary displacement of bilirubin from albumin. فبيطرد البيليروبين من الالبومين بحل محله بيعمل بروتين بايندينج، فبتشوف انه الطفل مثلا بيكون كيرنيكترس او عنده هايبر بيليروبينيميا. Biliary sludging, like particles in bilirubin or biliary particles coming off the bile ducts, has been also reported. 7 cases of fatalities were reported in neonates receiving concomitant ceftriaxone with calcium infusions. Therefore, calcium ceftriaxone precipitates, they were detected or found in lungs or kidneys of infants given calcium-containing products concomitantly with ceftriaxone within 48 hours from each other. يعني لازم نعمل spacing أكثر من 48 ساعة أو ما نعطيهم نهائيا. طبعا الأفضل إنه ما نعطيهم مع بعض. The fourth one is ceftazidime. It's also a cephalosporin. Due to recent shortage of cefotaxime, ceftazidime or dime has been used as an alternative because it offers same coverage and it's FDA approved for pediatric patients. So it could be used, achieves therapeutic concentrations in all tissues, including the cerebrospinal fluid. Has not been used extensively in neonates. Therefore, neonates should be closely monitored for the 2 important factors, safety and efficacy, toxicity and efficacy of this antibiotic. And you need to monitor for bacterial or potential bacterial resistance and other potential risks such as invasive candidiasis and necrosis of the enteric tissue and death. All of these have been associated with cefotaxime and neonates as well. Now we move from early onset sepsis into late onset sepsis. Now the empiric antibiotic treatment in this type of sepsis or meningitis should be directed toward the common nosocomial. The difference between early onset that happens during pregnancy or just during delivery process, but the late onset happens later on in the hospital, after a few days after delivery. The common nosocomial pathogens. What are the most common nosocomial pathogens or microorganisms available in that area or hospital? And the primary pathogens also for the early onset sepsis. So for many years, this empiric antibiotic therapy included a combination of gentamicin and vancomycin, since the cons is the most common causative organisms اللي حكينا عنهم اللي هو الكواجيليز group. And however, due to an increased emergence of vancomycin صار لها resistance كمان اللي هو Enterococcus and Staph aureus, the Center of Disease Control and Prevention has recommended against using vancomycin empirically. Empirically يعني بدائيا بدون ما يكون عندك results، تستخدم على عمي زي ما بيحكوا. That's why it's not recommended by the CDC, and vancomycin should be used selectively, very selective type of patients in infants with a proven كان عندهم cons أو صار عندهم اللي هو MRSA اللي بنسميهم اللي هو methicillin resistant Staph aureus bacteremia. It's very very common by the way this يعني MSRA إنه يصير في عنا هذا الانتيبيوتيك او هذا البكتيريا ريزيستنت للانتيبيوتيك، بالعكس هي بتدمر الانتيبيوتيك بدل ما يدمرها، فهذه المشكله اللي بتصير فيهم. And many neonatal centers are now using nafcillin or oxacillin in the place of vancomycin حتى يقللوا من هذه الchance or risk of vancomycin resistant organisms. كثير بنسمع عن antibiotic resistance، سوء استخدام، abuse of certain antibiotics. They will start with them, they will lead to microbial resistance. They are not susceptible anymore. For patients with spread HSV infection, should be initiated with IV acyclovir. Again, because the microorganism is a virus here, then the treatment is going to be intravenous acyclovir. And this treatment has been associated with a decreased mortality and morbidity in infants with CNS and disseminated disease. So if that meningitis is due to a viral infection, then the treatment is antiviral acyclovir. إذا كان عندهم those with skin, eye, or oral mucosal disease, IV acyclovir may also prevent progression to disseminated or CNS disease. فإله كمان another advantage طبعا في هذه الحالة. This table summarizes the antimicrobial dosage regimen for neonates وبيقسمها إلى فئات. طبعا في العمود الأول هنا في الشمال راح تشوف هو الأنتيبيوتيك من الأمبيسيلين والسيفازولين cefotaxime, etc. All of these antibiotics, including nafcillin, penicillin G, piperacillin, and vancomycin. We have also the antiviral group. We have acyclovir, and we have the antifungal drugs, amphotericin B, liposomal amphotericin B, and fluconazole. The differences in treatment, this table will give you what would be the exact regimen or the recommended dose based on body weight. So in the first category here, if you see when the body weight of the neonate is less than 1 kilogram or 1.2 kilograms. The next group, when the weight is between 1.2 into 2 kilograms. And the third category, when you have the weight 2 or more kilograms body weight. So if, as you see here, the factor they took into consideration is the body weight of the child, and the doses mentioned here in the number of, or the doses is in milligram per kg per dose, and how frequently you should give. So again, أنا الأرقام طبعا صعب نحفظها، هذا الجدول فيه بحدود 100 رقم، فصعب نحفظ الأرقام هذه كلها، لكن نعرف لما بذكر لكم بعض الأحيان في الكيسز الأرقام إنه بعطيك lower dose و higher dose، إنه إيش which one is preferred. يعني بعطيك الأرقام أنا بس تعرف إنه هذه هي ال higher dose وال lower dose, which one might be better. The other table here, we have also extended interval dosing for gentamicin for neonates. So this is the PMA, or the post-menstrual age of the child. If it's lower than this, taken into consideration the age of the child, below 32 weeks or 32 to 36 or more than 37, full term, of course, the last line. This is the extended interval, or the EID or EID dosing regimen. As you see, it's never below 24 hours. هذه بدنا نركز عليها لأنه مهمة من ناحية الفروقات ما بينهم وبين الأدلت. الأدلت حكينا بنعطي كل 8 ساعات، لكن هون لأنه extended interval فما راح يكون عندي 8 ساعات، أقل شيء 24 ساعة تغطي. وهذه حكينا انه حتى يكون في عندي good bacterial killing, and at the same time I have to have certain drug free period to avoid resistance against the antibiotic. فهذه مهمة باعتقادي حتى انه نحفظ الفترة الزمنية يعني اللي بنحكي عنها. Now, based on the Infectious Disease Society of America guidelines, the NICUs and high rates more than 10% of invasive candidiasis. Candida is a fungal infection. They should provide prophylactic. إذا كان في عندي higher risk more than 10% or higher rate of more than 10%, so if في عندهم fungal infection, then I need a prophylactic antifungal treatment. Prophylactic fluconazole. This might be given orally or intravenous at a dose of 3 to 6 milligram per kg per dose, twice weekly for 6 weeks to all extremely low body weight infants. فإذا حسب الانفايرمنت المحيطة فيهم إذا كان more than 10% بهذا النيكيو أو النيونيت أو النيوبورن intensive care unit صار فيها invasive candidiasis, then I need prophylactic fluconazole حتى يعني اضمن ما يصير في عندهم فانجل انفكشن especially انه invasive. اذا ما كان متوفر عندي فلوكونازول alternative او كان في عندي resistance طبعا against الفلوكونازول, alternative هو النستاتين, oral نستاتين at a dose of 100,000 units 3 times daily for 6 weeks can be used in very low body weight infants. So عملوا systemic أو systematic review, بيرجعوا لكل الدراسات اللي انعملت مثلا على البروفيلاكتيك فلوكونازول. They found prophylactic fluconazole to significantly decrease invasive candidiasis, which is good. Number 2, candida species colonization, and mortality also decreased in the extremely low birth and the very low birth weight infants. إذا هو نزل لي عمل decrease للinvasive candidiasis والcolonization of these candida species also get lower. Now, despite the benefits of a prophylactic fluconazole, there is also a problem. There is a concern for potential development of resistant pathogens. Some pathogens might be resistant towards this prophylactic treatment. And don't forget, this is considered kind of a long-term therapy with this fluconazole, which is associated with adverse effects. So that's why we need to have monitoring for those patients for potential short and long-term adverse effects associated with fluconazole. For systemic and neonatal fungal infection, now it gets into the blood. This is what we call it systemic neonatal fungal infection in this group. So we need conventional amphotericin B decarboxylate, deoxycholate. So this deoxycholate is considered the empirical treatment of choice. Then the empirical treatment of choice for systemic neonatal fungal infection is the conventional amphotericin B deoxycholate. Why did we call it conventional? Because we will see a different formulation now. It's called liposomal amphotericin B. Again, fluconazole may be considered as initial treatment in infants who have not received prophylactic fluconazole due to potential resistance. And liposomal amphotericin B, it's a different formulation, may also be used as an alternative, but not for the treatment of urinary tract infections due to its inadequate penetration into the kidneys. ما له good penetration هذا اللايبوسومال into the kidneys, لذلك it's not recommended في هذه الحالة. Increased also rate of mortality associated with liposomal amphotericin B لما نقارنه مع الفلوكونازول أو الconventional amphotericin B. Therefore بيعتقدوا الدراسات طبعا انه الconventional amphotericin B and fluconazole, they are considered the drugs of choice for empiric therapy of candidiasis. For both early onset and late onset sepsis, once a pathogen is isolated and antimicrobial susceptibilities are available, طبعا antibiotic therapy should be tailored accordingly. يعني انت في البداية اخذت كلتشر، عملت كلتشر من البلد او السيرم سامبل وبلش بالامبيريك تريتمنت، الان ظهرت النتائج، then you might change this treatment accordingly. It could be the same, by the way, but you need to optimize that or tailor it accordingly, whether this is more efficacious drug, for example, will better cover that microorganism, then you change that regimen accordingly. So blood, cerebrospinal fluid, and or urine cultures should also be repeated 24 to 48 hours after the initial blood culture to ensure bacterial elimination happened. So you gave the treatment, then you need to take another sample, whether it's from blood or cerebrospinal fluid or urine, to make sure that this antibiotic is really working, because you don't know what if that in that patient this antibiotic is not working perfectly fine. So you need to double check to make sure it's effective. And again, we're talking about very serious infections here. They are serious infections. We'll move now to the duration of therapy. What is the recommended duration of therapy? So in neonatal sepsis and meningitis, the treatment duration of culture-proven sepsis varies from 10 to 14 days. So that's the course of antibiotic that they normally have to use. إذا كان عنده meningitis, the duration of therapy varies depending on the organism. برضه حسب المسبب يعني. What is the microorganism? For example, if it's a gram-positive pathogen, infants should receive at least 14 days of therapy. Negative بيكونوا more virulent, more aggressive, more invasive. The gram-negative pathogens, we need even a longer course of antibiotic. We need about 3 weeks or 21 days. In general, antibiotic therapy should be continued for a minimum of 14 days after the repeat CSF culture is negative. فإذا ظهرت CSF إنها negative, يعني بعد ما بلشت تعطي الانتيبيوتيك, should be continued for a minimum 14 days. الآن في بعض الحالات ممكن نحتاج إلى duration أطول شوي. Infants with abscesses إذا كان عندهم دمامل, osteomyelitis or endocarditis, that infection went to other organs, they may require longer durations of therapy. Oftentimes, the clinicians also, they might select or choose to continue antibiotic therapy for up to 7 to 10 days in infants with culture negative sepsis. كانت الculture negative sepsis who appeared clinically septic or who may have abnormal laboratory tests, إنه يضيفوا كمان 7 to 10 days حتى يتأكدوا إنه ما في عندي مشكلة، إنه they appeared clinically septic or إذا كان عندهم برضو abnormal laboratory results شاكين فيها بيكمل على الانتيبيوتيك. Cardiorespiratory instability in very low body weight infants is common and should not justify the need for prolonged antibiotic therapy. يعني بعض الأحيان ممكن يظهر عندهم مشاكل كانت في cardiorespiratory instability should not justify, فممكن نختصر شوي إذا كان في بعض المشاكل زي هاي. Unnecessary and prolonged antibiotic can lead to long-term complications. Therefore, it's really sensitive here to decide what is the exact duration of a treatment do I need. There is no need to keep the child on long antibiotic if it's not needed, if it's unnecessary. If it's a prolonged, it's always think about the long-term complications. And again, benefit risk. So an increased risk of the necrotizing tissue and death is reported with extremely low birth weight in neonates exposed to prolonged antibiotic therapy within the first week of life. يعني ممكن تخسر حياته للطفل خصوصا إذا كان الوزن جدا قليل، لو extremely low birth weight مع long exposure of antibiotic you might lose their life. You could save their life by giving the right duration of a treatment. So this may be due to the fact that antibiotics may promote dysbiosis. Dysbiosis اللي بشوف الصورة على اليمين هون عندنا symptoms of dysbiosis اللي هي إعادة انتشار النورمال فلورا. هذا النورمال فلورا بتغطي مناطق من الجسم على بالجت gastrointestinal system على skin and respiratory tract. فانت لما تعطي longer duration antibiotic ممكن تقضي على كل هذه الانتيبايوتيك normal flora وبتعمل you promote dysbiosis. normal flora it gets distracted or you damage it. Therefore, for those with negative cultures, antibiotic therapy should be discontinued by 36 to 48 hours. يعني مجرد ما طلعت عندك نتيجة انه negative فبالحالة هاي طبعا discontinue 36 to 48 hours within that time frame. الريزلتس بعض الأحيان لما تحصل على results من laboratory values or tests إذا كانوا abnormal they should not be used solely to continue antibiotic therapy. يعني ما بنقدر نعتمد عليهم لوحدهم حتى نحكي والله this is a good reason to continue antibiotic therapy. الكالتشر بتكون more accurate in this condition and clinicians should always weigh the benefit risk of continuing antibiotic therapy in those with culture negative symptom or sepsis and discontinue therapy as soon as there is a clinical improvement and laboratory markers are returning to normal. معلش بس آخر two slides. Aminoglycosides they may cause زي ما بتعرفوا بحالة الثيرابيوتيك دراج مونيتورنج الآن. هون بنحكي بشكل عام عن ال TDM أو Therapeutic Drug Monitoring عن السايد افكتس والافيكاسي basically especially aminoglycosides. حكينا عنها في بداية اللكتشر اليوم إنه we have to monitor for nephro and ototoxicity. important طبعا to maximize efficacy and reduce toxicity. فبتركزوا على البيك والتروف readings for aminoglycosides like gentamicin etc. فهذه لانه بياثروا على الكدني ممكن ياثروا على الايرز وبالتالي حتكونوا very effective. وكله بيحكي طبعا عن التروف تو بيك ريشيو والكونسنتريشن تكون within the range. وsimilar to gentamicin كمان عندنا vancomycin might also or can cause nephrotoxicity but exert a time dependent killing. Again بيحكي عن السيرم trough concentration انه كيف لازم نتحكم فيها. وفي عندي targeted vancomycin trough concentration units remains controversial انه في حالة الvancomycin في اختلافات عليها. طبعا في شوية ديتيلز عليها في الشابتر فبتمنى انه كل واحد يقرأها. هي اعادة تقريبا اللي حكيناه في البداية لكن بهمني تفهموا البرنسبل تبعها انه why do we need to have a TDM or therapeutic drug monitoring for aminoglycosides? What is the importance of this step and how this would affect the dosage regimen in those patients? فبنكتفي لهذا القدر وبنكمل ان شاء الله يوم الثلاثاء القادم